Good day, everybody. Today, we're going to discuss iron chelation. And as you know, iron overload and good iron chelation are vital to the survival and of patients and the prevention of complications. With us is Dr. Farooq Shah, consultant hematologist at the Whittington Hospital, London. I'm sure most of you, if not all, know her very well. She is a consultant who has devoted actually most of her career to the hemoglobin disorders, both the thalassemia syndromes and sickle cell syndromes. I do not think that she needs any further introduction. So Farooq, it's up to you now.
Okay, thank you, Michael. Very kind introduction. I'm going to cover iron overload in both thalassemia major and in the non-transfusion thalassemia syndromes. And we're going to talk about monitoring and management. And I'm going to apologize in advance. There's a lot of slides because it's a lot of information to cover. So it will be pretty fast moving. So we're going to cover the complications of iron overload and then talk about how you diagnose iron overload, monitor it, and then how you manage it. And then I am going to cover a bit of compliance because that's actually very dear to my heart. It's all very well us giving people iron chelation and doing the monitoring, but if people don't take the medication, then we're basically not doing anything. So why is it important to diagnose iron overload? Well, iron overload actually causes a lot of morbidity and is responsible for the mortality that we see in thalassemia syndromes. And ferritin is not the most reliable test, and confirmatory tests are really important in ensuring that we actually know what we're prescribing iron chelation therapy for. There's a massive spectrum of transfusion requirement in thalassemia syndromes, from people needing regular, long-term, lifelong blood transfusions to people who occasionally need transfusion. But the entire spectrum of patients can actually develop iron overload. So even the non-transfused patients develop iron overload from increased gastrointestinal iron absorption. And those patients are often very badly managed because they're not monitored appropriately for iron overload. And we need to ensure that when we are thinking about monitoring, we're looking at the entire population of patients. So the complications of iron overload that we're aiming to manage or prevent primarily with the thalassemia syndromes is problems with growth, sexual development and fertility, the development of diabetes, hypothyroidism, hypoparathyroidism, and obviously the osteoporosis. These are the non-fatal complications. And they cause a lot of long-term morbidity for the patients and really impact on their quality of life. However, there are fatal complications which really happen if there's been a prolonged period of poor compliance with iron chelation or actually no iron chelation whatsoever. And this is the situation where we all sort of react urgently, but we need to be thinking more about both the long and the short-term sequelae of significant iron overload. So cardiac failure obviously is really important, but also there's an increased predisposition to infections, particularly with Yersinia and Klebsiella. In the UK, the commonest reason for death in a thalassemia patient today is actually Klebsiella infections. It's not cardiac failure in our population. And then the long-term sequelae of prolonged iron overload, hepatocellular carcinoma, liver fibrosis, liver cirrhosis, and liver failure. And it's really important when we're talking about monitoring for complications that we don't forget the simple visual. This is a thalassemia patient who's really well chelated. This is a thalassemia patient who's very poorly chelated. And you don't need a serum ferritin or an MRI scan to tell you that this patient has got very severe iron overload. And we need to remember to look for the visual markers for iron overload in our patients. So we're going to move on to diagnosis of iron overload in the thalassemia population. So the diagnosis is using a number of strategies. It's mainly by either measuring the amount of iron in one form or another, or it's about measuring for the effects of iron overload damage in one form or another. So tissue iron estimation is done by ferritin and by measuring the amount of iron in the liver or in the heart. And the effect of iron overload is measured by looking at function. So in the heart, you'd be looking at ejection fraction and cardiac function, looking at probably soft signs of diastolic compromise. And for the endocrine, you're looking for end organ damage predominantly, with pituitary, diabetes, hypothyroidism, and hypoparathyroidism as being the main things that you would be looking for. The serum ferritin has a linear correlation with iron overload, but it doesn't tell you the amount of iron in the liver. It will tell you if it's high that there's iron overload. If it's low, it will say that there's probably not much iron overload, but it doesn't tell you the actual amount. So serum ferritin reflects the iron stores. It also reflects recent chelation and the type of chelation a patient's had. It affects inflammation. And we certainly see a number of people with very high serum ferritins where fatty liver disease, in fact, or alcohol is impacting on the serum ferritin results. It also reflects tissue damage and vitamin C status, and low levels of vitamin C will give you artificially low serum ferritin results. And when the patient's iron burden improves, the ferritin actually goes up and normalizes. And it's an important thing to remember in your very severely deficient patients that vitamin C deficiency may be contributing to an artificially low serum ferritin. And then, of course, we've got the non-transfused patients. And we know from Ali Tahir's data and also Rafaela's data that the serum ferritin does not reflect the iron burden in patients with thalassemia intermediate. It is artificially low in this population. And we should be reacting at much lower serum ferritins if someone is non-transfusion dependent. This is data from the Whittington Hospital. We looked at our patient population, and these are patients who'd been stable on the same chelation regime for at least 12 months. And we looked at the serum ferritin and the liver ions in this population. And what you can see is that for a similar liver iron level of about 5 in the majority, with a very similar range, in fact, for those patients as well, the average ferritin in people with desferal and deferocyrox was very similar, but deferiprone actually does push down the serum ferritin considerably. But the liver iron is about the same. So it's important to remember that a ferritin of around about 1,000 in someone who's on deferiprone may reflect higher iron burdens in comparison to the same ferritin in people with ex-JADE or with desferal. And we know that liver biopsies are one of the old methods for measuring liver iron, and it's important that we don't forget that liver biopsies provide other information, particularly around the severity of the fibrosis and the distribution of iron. So if you have no choice and you do not have access to MRI assessments, then liver biopsies should not be forgotten, and we should be thinking about doing those, certainly in low resource environments. Why is liver iron important? Well, liver iron predicts the total body iron stores. So we know that if you've got a high liver iron, you've got a high total body iron store. And this is data from Angelucci's group looking in the post-transplant setting. So if you've got a high liver iron, you're more likely to develop iron-related complications because of your increased total body iron. And we know that the liver iron also links directly to long-term prognosis. And this is data from about 20 years ago now, but it still stands very true, looking predominantly at the patients from London, that if you've got a very high liver iron, there's an increased mortality. And if your liver iron is well controlled, this is liver biopsy data. If your liver iron is well controlled, then your survival is much better. And group 3 are the patients with this very significant decline in mortality. One of the things that I often remind people to do is to, if they don't have access to serum ferritin, is actually to look at the liver enzymes. Transaminases go up with iron overload, and this data from Jensen's group, looking predominantly in myelodysplasia, shows that there's a pretty good relationship with a liver iron that's high and the presence of transaminases. And there are many things that cause me some concern around how people react to transaminases, particularly around iron chelation, with the assumption being that the iron chelation drug is actually causing the transaminitis, when actually in someone who's got significant iron overload, the transaminitis may in fact be because of the iron overload itself. So it's important that this data is interpreted very carefully. But if you do have a high liver enzyme level, then you've got to be thinking that this may be actually reflecting significant iron overload. This is basically data, again, from Angelucci's group, showing that a liver iron of above 15 is associated with an increased risk of fibrosis in this population. And that makes it very important that we do control the liver iron as much as we possibly can. So I've done a lot of talking about liver iron. Well, there's a lot of controversy about liver iron around what method you use for measuring liver iron. And there's a number of MRI strategies that we do use. There's the T2 star, which gets done as part of the cardiac T2 star. You can use R2 star as well, which is basically T2 star is 1 over R2 star. It's just a mathematical calculation. Or you could do R2, which is currently the strategy used by Resonance Health for the FerryScan MRI scans. This is the original data from Anderson, and this is the original calibration curve for the T2 star methodology in the T2 star technique. What you can see here is that if the liver T2 star is very low, so this is below 1 millisecond, you've got this massive range of liver iron burden, and that tells you that the liver iron is not reliable below a certain T2 star value because the interval for measurement is very, very short. And that means we need a better strategy. Likewise, it tells you that with the low liver irons, that's a liver iron of below 5, your T2 star could be anywhere between 5 going up to 15, but it's far more reliable as a tool in people with very low liver irons and therefore high T2 star values for the liver. Now, the comparison of T2 star versus R2 in the literature, you have to use a formula to calculate the actual value based on the calibration for the R2 star. And what you can see here is that with this formula calibration, looking at the R2 star, you've got a liver iron of 5 on the Anderson technique. But if you use a slightly different calibration using the Christophordes calculation, for example, you may end up with a liver iron of 26. Now, I would behave very differently for my patient with a liver iron of 5 in comparison to someone with a liver iron of 26. So what I want to say is that the T2 star technique is very good, but you have to look at the calibration that's being used, and you have to interpret that liver iron value with caution so that you actually don't underchelate your patient when they need better chelation therapy. With the R2 methodology, you get a report which is like this, which will give you a value for an average liver iron concentration. And that actually gives you a pretty good visual example of what happens with high liver iron levels. Right, deep breath. We're going to talk about cardiac T2 stars. So T2 star is the technology that was developed in 1999 by Lisa Anderson and Dudley Pennell at the Royal Brompton Hospital. And this has transformed how we manage our thalassemia patients. Prior to this, we were using muggers and ejection fractions for monitoring our thalassemia patients. But if you think about it logically, when the patient's got a heart failure, they've already got very severe iron overload. And what you really want to do is prevent the cardiac iron from developing in the first place. And T2 star allowed us to do that. And we know that the T2 star value reflects liver iron, cardiac iron. And you can see this is a cardiac biopsy with iron. And you can see someone's got a very black intraventricular septum. And this is a biopsy, cardiac biopsy image taken by Dr. Westwood from Professor Pennell's group at the Brompton. There is a severe discordance between cardiac and liver iron. And I think one of the things, and I hope everyone now follows that this is an important thing, is that the direction of travel for iron movement is different. So you cannot look at this data in a cross-sectional kind of a way. And here you've got someone with severe cardiac iron loading, but not very much iron in the liver. And here you've got someone with minimal cardiac iron loading, but really very heavy iron loading. This is the first stage. You load iron into your liver, and then you load iron into your heart. And when you chelate, iron comes out of the liver first. So this patient's been chelating very well, but iron comes out of the heart later. And so you do end up in situations, if you're just looking at a snapshot, where you've got no iron in the liver, but you've still got a lot of iron in the heart. And so it's important to remember that there is a journey that the patient is on, and you cannot look at numbers as a cross-sectional analysis for patients with cardiac and with severe hepatic iron loading. This patient will go on to develop cardiac iron loading if they don't chelate. This patient will remove this cardiac iron loading if they continue to do what they're doing, which is very clear that they have managed to successfully clear the iron from the liver. Poor chelation means that you develop iron overload in the heart, particularly very early. And this is data from China looking at children who are poorly chelated and who have got significant cardiac iron loading. And I think the real eye-opener from this data is that we're talking about children below the age of 12, and some of them below, around the age of 6, at the age of the first MRI scan. So getting the iron chelation very good in early childhood is actually really, really important. And that's where the patient's parents play the most important role. And it's about how we educate the parents to make sure that they avoid this situation from developing. We know that cardiac T2 stars below 6 milliseconds from the Brompton group are associated with an increased mortality. And this data from Kirk et al., looking at all of the patients who'd had MRI scans over the years in the Brompton cohort, shows that a T2 star of below 6 is associated with pretty close to a 50% mortality or a risk of going into heart failure in this population of patients. There is a new technique called T1 mapping. We use this at UCLH in our patients. And this is really good because it allows you to do a very, very rapid image of the situation for the heart. And you can actually see a much broader spectrum of cardiac iron overload. And it does correlate linearly with T2 star. But you can actually identify early cardiac iron loading, even when the T2 star is considered normal, and that means when it's above 20 milliseconds. And this is what the T1 MOLY imaging looks like. And what you can see here is a healthy control in the first box with no iron in the heart. And then as you see, the blue starts to appear in the intraventricular septum. And here the patient's T2 star was 19 milliseconds. Here, the cardiac iron is getting worse, and the T2 was 10 milliseconds, and here it's totally black, and the T2 star was 4 milliseconds. So you get a really good visual, which patients really do appreciate. So T1 mapping improves reproducibility. It's a shorter breath hold. It gives you a very good visual, and it's an early detection of iron overload. And there's less regional artifact in doing it. And we do need more centers to start to do T1 mapping for their patients. So I'm now going to move on to monitoring. So what we do when we monitor patients is that we monitor the iron burden. We monitor the toxicity of the chelator. We also monitor for complications of iron overload. We monitor for compliance. And this is an MRI assessment for a patient using FerriScan. And what you can see is that the liver iron is really very good. But then if you look at the serum ferritin, the ferritins are actually really very, very high. And this is why the ferritin can be discrepant, and it's important to not make judgment calls purely on what the serum ferritin is doing. And here's another one of our patients at the Whittington, and what you can see here is that the liver iron is really very, very well controlled. And what you can see here is that the ferritin moves in line with the patient's iron burden. So trending the serum ferritin is actually extremely important. What we can see from outcome data for patients with the impact of proper monitoring is the fact that the mortality in the UK fell dramatically with the intervention of MRI assessments in our patients, and we lost far fewer patients from cardiac iron loading. And if we look at the more recent data set in our patients, what you can see is that we now no longer lose patients from heart failure because of cardiac iron loading. And the commonest reason for death is infection, which is actually mainly driven by Klebsiella. And the FerryScan monitoring, this is Whittington Hospital data, but what you can see in our patient population is that regular monitoring with the R2 methodology allows patients to move from the severely iron overloaded zone into the minimal or optimally iron overloaded zone. So the monitoring standards are annual assessment for liver iron using any method, T2 star, FerryScan, whichever one is available. And you should be aiming for a liver iron of below 5 in an ideal world, but ideally between 3 and 5. And you should certainly consider T2 star monitoring for all patients on an annual basis. But if you can, you should be doing T1 mapping because it's cheaper, easier, and quicker to do. So I'm now going to go on to iron chelation therapy. And we all know that there are 3 iron chelation drugs that are in use, Exjade, Desferal, and Deferiprone. But we actually have 3 iron chelation drugs, but 6 iron chelation regimes. So we've got a very big spectrum of therapy that we can actually use. There are no new iron chelation drugs in development at the moment. And the last set of iron chelation drugs were unfortunately withdrawn because of renal toxicity in the patients. So what can you see? Well, we can see that the important thing here in this data set is the control of non-transferrin bound iron or label plasma iron. And if you use Desferal or Deferiprone or combination, what you can see here is that all the drugs do control NTBI to varying degrees. So Deferiprone, if you take the tablet, the NTBI goes into control. With Desferal, it's high levels during the day, but controlled when the pump is on. If you use combination therapy with Desferal and Deferiprone, you get good control both at day and night. And Exjade allows non-transferrin bound iron to be controlled, again, over a 24-hour period. And what you really want to do is control the labile iron because that's the toxic species of iron. Everyone on the call probably knows this data already, but I'm going to quickly whiz through the survival data and the complication data. So with Desferal, you can get skin reactions, which are managed using hydrocortisone. Patients can get a risk of yersinia. So in anyone developing fever and diarrhea with Desferal, you should stop the Desferal until the diarrhea has resolved and the fever has settled. And then chelated toxicity. So hearing, audiology assessments are really important. Ophthalmology assessments, there is a risk at very high doses of night blindness going on to daytime blindness. And we monitor this by doing electrophysiology assessments in our patients. But you should be using the therapeutic index, which is a very simple calculation to make sure that you're using Desferal at safe levels in these patients. And we can give Desferal through either subcutaneous infusions or through portacaths. And we know that Desferal is very important in preventing complications and very important in survival. And you can see death at 20 in the 1980-84 cohort is about 1% from the Italian data. And although these graphs are all old, they hold true in that people who chelate well with Desferal do very well. We have Deferricirox, which we now have used for about 15 years. And we know from the clinical trial data that this does control liver iron very effectively and controls serum ferritin very effectively. And the drug is really very well tolerated in the vast majority of patients. And the first year is obviously difficult with a lot of side effects, but once wraparounds and workarounds have been developed for the side effects, the side effect profile remains extremely good. The main issue with Exjade is the renal toxicity, but that tends to happen at very high doses at low levels of liver iron. And the GI toxicity, we are seeing a lot of people develop gastrointestinal side effects. both with the soluble XJade as well as with the tablet formulation. And it's very important if your patient's complaining of abdominal pain that you look for evidence of Helicobacter pylori, you look for evidence of ulceration, and you reduce the dose if it's needed to reduce the dose. People always say to me, well, does XJade work on the heart? And my answer is yes, it does. All the chelators work on the heart, but the important thing is that you have to be giving the right dose and the patient has to be taking it every day. And this is data from the Cordelia study showing over a period of time that cardiac iron really does improve in a similar rate to what Desfral does. So XJade and Desfral are probably equivalent in their function in a thalassemia patient with cardiac iron overload. And then deferiprone. So deferiprone orally given 3 times a day. It is a very effective iron chelation drug, but it's got a very, very short half-life. And I've had patients who've taken all their deferiprone tablets in one go in the morning, and then they get 1.5 hours to 3 hours of iron chelation. It's really important for patients to understand that deferiprone has to be taken 3 times a day. It's got a short half-life. And until they understand that, you often get very sort of discrepant results for your patients around removal of iron. There is a risk of neutropenia and agranulocytosis, and this does need to be monitored. We bypass the gastrointestinal side effects in our patients by starting at a low dose, usually 1 tablet a day, and then increasing the tablets on a weekly basis. So they do 1 tablet a day for a week, then go to 2 tablets a day, then 3 tablets a day. Clearly at the same time, they're doing their Desfral, but that actually helps us to bypass some of the gastrointestinal problems with nausea, vomiting, and diarrhea. About 15% of patients can get joint pains. It's really important if a patient is complaining of joint pain that you take this seriously and actually arrange for MRI assessments if needed, or at least an X-ray. It can cause significant arthropathy, so it's very important to monitor and prevent this if at all possible. Deferiprone, if you compare it to Desfral from the original studies done by Professor Pennell, improves cardiac iron faster than Desfral. But it is important that this data is interpreted with caution, particularly around doses of drugs that you're using for individual patients. The combination regimes that we have now are Desfral with deferiprone, which is a very old combination we've been using for the last 20 years or so. And then we've got the new combinations, which is XJade with Desfral and deferiprone with Desfral. And why is this important? Well, there's some really good evidence from the laboratory which shows that there is a synergy between these drugs when you use them in combination. And if you look at the synergy index for these drugs, the most synergistic is actually the 2 oral drugs taken together. So deferiprone with XJade has a synergy index of 0.59. And the other iron chelation drugs, deferiprone and Desfral, 0.51. And the least synergistic is XJade with Desfral. But all of the drugs are actually synergistic when used in combination. Desfral and deferiprone we've used for many, many years, and I'm going to really whiz past these slides. But what you can see is that this drug is highly effective, this combination, in removing cardiac iron in patients and actually clearing liver iron. If you look at the deferiprone and XJade combination, this is, in comparison, this is from Mohsen Al-Fafi and his group. And what you can see is that the patients who are getting the 2 oral drugs in combination are doing much better than those patients who are using Desfral and deferiprone in combination. And then finally, we've got the XJade and Desfral combination, which was done as part of a clinical trial looking at cardiac iron-loaded patients. And what you can see here in the hyperiron study is that there is a significant improvement in patients' liver ions on this combination. And once you get past a certain threshold, the cardiac iron starts to improve as well. So you have to have a liver iron of certainly below 30. And once it's below 30, you get a very dramatic improvement in the T2 star. So what is the situation now? Well, we've got 3 drugs. We've got multiple regimes for our patients. We've got monotherapy, we've got combination therapy. We should be targeting therapy for our patients based on our individual patient's need. It should not be that one therapy is the one that we use for everybody, and individual patients' requirements should be tackled and dealt with. So what we recommend in the UK, and this is part of the new BSH guidelines, is to start with monotherapy regimes which control both hepatic and cardiac iron. Consider combination with desfral and deferiprone in people with cardiac iron loading or those with poorly controlled iron burden with monotherapy of desfral or deferiprone. And consider combination therapy with desfral and XJade in very severely iron overloaded patients, particularly those patients with cardiac iron loading who cannot take deferiprone because of previous side effects and complications. And consider deferiprone and XJade in patients. There is limited efficacy data, but this is building up on a monthly basis in our population. And we are definitely recommending that deferiprone and XJade are used in combination in people with significant iron overload and or side effects on monotherapy with one drug or the other. So iron chelation is really important, but compliance is equally important. And what you can see here is our data looking at FerriScan MRI assessments and in people with optimal and suboptimal compliance. And what you can see here is that the impact of the initial scan, even in the suboptimally compliant patients, resulted in a significant improvement in their iron burden because of the visual picture of what was happening. And this happened across all of the iron chelation regimes that patients were taking. So in my last few minutes, I'm going to talk about strategies for difficult patients. And these are really very much focused around adherence to iron chelation therapy. Adherence is a universal problem, and this is a problem with all medications and with every single medical condition. This is not unique to the thalassemia patients. And if I had to take an iron chelation drug that gave me side effects every single day, I can promise you I would not take my drug every single day. And we need to remember that our patients have to do this for the entirety of their lives. And we have to make sure that the regimes that we give our patients are things that the patients can take and tolerate. And no patient is going to be on one regime for their whole life. They are at different time points going to need to switch regimes to tackle individual problems that they develop or to help make things easier for them if they're running into problems. The big problem is early iron overload is asymptomatic, and the only way we know our patient's developing iron overload is with monitoring. But the patient feels well, they've got no symptoms, and they may not realize that they've got a side effect that is developing or maybe developing. And they don't feel any benefit from taking the iron chelation therapy. So when my patients have gone off to university, they often disengage with their therapy because mum and dad are no longer reminding them to take their iron chelation therapy. And because they feel well, after a week of having a drug holiday, they've got very little inclination to start back on their medication. And then it's easy to let things drift. So back to the thing about managing side effects. We have to talk to patients about what's stopping them. Why are they stopping their medication and what is driving that? Last night I saw a patient in my clinic. He's on XJade. His liver iron's been going up, his ferritin's going up. He's at university, as is the normal case for these patients. And he's on XJade, and I said, well, why aren't you taking it? And he goes, well, I miss it once a week. And if I've you know, got a stomach pain or something like that, or if I've forgotten to have my food, then I just won't take it. And, you know, it's causing me stomach problems now. And I said, well, why don't you switch the medication to twice daily? And which meal of the day do you eat regularly? And he said, well, I eat lunch sometimes at 3, but I do eat lunch and I do eat my evening meal. And I said, well, okay, well, let's do BD at lunch and in the evening. And he's going to try that. And it's about developing a strategy that works for the patient and talking to them about a solution that they can deal with. If you're using dispersible XJade, taking the XJade with food, dissolving it with lukewarm water, doubling the volume of liquid, telling the patient they don't need to drink it in an hour, they can drink it in 2. These are all things that help individual patients. If people get side effects with XJade, in particular diarrhea, and they've got to go to work and college, they're not going to take their XJade. So advising them to take it in the afternoon or the evening when they're at home will help them. If they've got very bad nausea, then considering antiemetics, thinking about acid suppressant therapy, thinking about Helicobacter pylori. It's about that conversation that you have with a patient, and it's about you helping them find the solution that works for them. And sometimes it's about saying, well, actually, nothing works. Let's switch over and change to a different drug. Renal side effects with XJade are significant. So to consider doing a dose reduction, make sure to monitor for other causes for renal problems. In particular, I've had problems with renal stones in some of our patients who've developed hydronephrosis, and we've actually been reducing the dose of XJade with no net benefit because the patient actually had an unrelated problem causing the renal impairment. So if there is something that is outside of the normal range and you're not sure, scan, do images, and think about other reasons, because our patients are at the end of the day human, and they will develop other problems which are not necessarily related to thalassemia. Hepatic problems, particular transaminitis, very common in thalassemia patients, particularly in children at the start of therapy. So we start with a low dose, and we do very low dose increments until patients are on optimal doses. And we don't adjust XJ doses unless you're above 3 times upper limit of normal. So final bit is around barriers to compliance around life. Talk to your patients. Look at what's driving their challenges for their compliance. Talk about peer pressure for them and how that impacts on why they may or may not be doing their therapy. And try and keep their regimes as simple as possible. And remind your patients it's very important that their beliefs and motivations around a good outcome are very important for them. They have to have hope and expectation that the future will be better for them. And they need to know that the only way to prevent problems from developing is around compliance. So I just want to say thank you very much. And I think we've managed to find some time to ask questions.
Yeah, we have. Actually, one thing I forgot to mention in my introduction, but which has become obvious to everybody, is that Dr. Farooq Shah is an excellent teacher and makes difficult details much more clear. So, are there any questions, Rawad?
Is there any argument concerning DFO and kidney problems, low ferritin around 300 with medium liver fibrosis? What regimen of chelation should be taken?
Thank you, Andrila, very helpful. I didn't get the whole of that question because of your face mask, but I think the question's around ferrosirox and low serum ferritins.
It's around DFO and kidney problems. Is there an argument, it says, concerning? And then there is low ferritin around 300 with medium liver fibrosis. What regimen of chelation should be taken? So they're really concerned about the low ferritin around 300.
Yeah.
And what chelation should be related to that low ferritin?
Yeah, so what we would do around renal complications is obviously to do a dose reduction with XJade, reassess the liver iron burden and make sure that there's no significant discrepancy between the liver iron burden and the renal impairment. Because if there is a discrepancy, so the patient's liver iron is 5 or 6 on an MRI scan assessment, but they've got renal impairment, you need to be looking for other causes for renal impairment. So thinking about hydronephrosis or other problems. With a liver iron of, with a very low serum ferritin, I would recommend a dose reduction of the XJade, but I would actually persist with XJade. Because even if you're using a low dose of XJade, we know that there is data to show that liver fibrosis does improve over time with both XJade and with Desfral. I wouldn't change over to a 3 times daily regime with deferiprone if a patient's already comfortable with XJade. I would just reduce the dose rather than stop. And I'm very, and I would go down to a low dose, maybe 360 milligrams once daily for an adult, because they're going to continue with blood transfusion. Their iron burden will go up. And I've got a patient that last night I spoke to in clinic who's got a ferritin of 224. And I've basically told him that he's got to reduce his XJ down. He's on regular blood transfusion. So I've said, go to 360. Renal function is fine. Liver function is fine. And I've said, let's wait until your ferritin's above 400 before we consider a dose adjustment. Going up again very slowly, maybe by 180 or 90 milligrams, but trying to keep his ferritin close to 500 from a stability point of view. I wouldn't want his, and he's got cardiac iron loading, so I wouldn't want his ferritin to go above 500, but I'm a little bit outside my comfort zone with the ferritin going down to 200.
Mm-hmm. Thank you very much. I usually receive patients with very high levels of ferritin where they are using the Deferazirok's maximum dose. Is it fair that I start them on combination therapy, or should I start them on the Deferazirok's and wait?
Yeah, so it's about complexity of a regime. The more complex your regime, the less likely you are to do your therapy. And it's really important to keep it simple for patients. If they're doing well on XJade, they're tolerating it, and their transfusional iron loading rate is not very high, then I would persevere with XJade and give them at least a very good 6-month period of time to assess what the ferritin is doing. If the iron burden is going down, then great. I would carry on with XJade. Now, if they've got a very high transfusional iron loading rate, which is calculated using a simple formula, and the XJade dose, even at maximum dose, may not be enough to bring down the iron burden, then I would consider adding in combination therapy. But I would probably only do that after about 6 months of stable period on the XJade regime to see what's happening with the ferritin. But it is very dependent on the amount of iron entering through blood transfusions and making sure that you're on an appropriate regime. So if a patient's got an iron loading rate of 0.6 milligrams per kilogram per day, then maximum dose XJade isn't going to necessarily be enough to control that iron burden. So I would push to add in combination therapy in that situation, because you're going to be fighting a losing battle at that point.
Thank you very much. But there is a question that how to use this Feral, and is there an impact on the results while using it by pump or without pump? I think this is a trivial question. I think
there's a worry about with Desfral. So Desfral, you should be using the therapeutic index.
With the pump, yes?
Yeah. So with Desfral, be very, very careful. Therapeutic index is really important. We have retinal and eye toxicity. So eye toxicity and hearing problems with high doses of Desfral. Please do not use very high doses of Desfral without monitoring the therapeutic index and making appropriate dose adjustments. I have heard people using 100 milligrams per kilogram per day of Desfral in their patients. you can only actually bind a certain amount of iron at any one point. There is only a certain capacity for mobilizing iron within the body. And we know from research data done in Prof. Porter's lab that if you go above a dose of 60 milligrams per kilogram per day, you are not going to remove any extra iron. If you're measuring the urine ferrioxamine levels, it will remain the same, even with higher doses. So stick to a dose of 60 milligrams per kilogram per day for Desfral. Make sure you're monitoring for toxicity using the therapeutic index and avoid going above the therapeutic index. Regardless of what's happening with the cardiac iron, your patient will develop really terrible complications, and people today shouldn't have those complications.
Thank you. Would you consider to re-challenge with eCHADE if a patient previously had significant proteinuria and glomerulonephritis, which has now resolved?
Very important question, and the answer is yes, I would consider a re-challenge, but I would start at a low dose, maybe 7 milligrams per kilogram per day on the tablet formulation, maybe 10 milligrams per kilogram per day on the dispersible formulation. And then I would monitor the patient very carefully to make sure that they're not developing proteinuria and that you're actually keeping an eye on what's happening with the renal function. Remember that our patients are alive today. We have 60-year-old patients alive today because they were using Desfral. It is your fallback position for all of your patients. So if they can't tolerate an oral regime, it's really important for you to have a frank conversation with them about what life expectancy and prognosis is like with the Desfral formulation, and to try and build confidence and encourage and support the patients around using Desfral.
Since we have you on the line, Dr. Shah, can you tell us how many patients you have on Rebrogil, on this new drug?
Is that with eCHADE and Deferiprone, or is that with...
No, the Rebrogil, with luspatercept.
Oh, with luspatercept. In the UK at the moment, we have not got luspatercept available. It has to be, we've only got people on clinical trials.
On clinical trials.
When NICE approve it, we will then be able to use it.
Okay.
But until NICE approve it, we can't use it.
Have you already thought of making a certain guideline or monitoring for the use of this drug?
Yes, we will be, NICE will develop a guideline around the use of Reblozyl. Okay. And there will be a policy around how you manage people on this. And I think the UK's general view is that it's not going to work for everybody. It's really important to remember it's not going to work for everyone. Okay. We will offer it to people, assess what's happened with the transfusion burden. If they've had a very good response, we continue, but if they've not had a good response, we will stop.
Thank you very much. So I think this is all for the questions. Dr. Mike, you have any questions?
Yeah, actually, there's been a lot of questions on iron chelation, how to manage things. I wanted to go a little bit further back to your monitoring suggestions. Mm-hmm. Monitoring, especially with MRI, is extremely important. You demonstrated that it saves lives and saves complications. But our trust, if you like, of the accuracy across the world, and don't forget that most of the questions that we've been having are from countries which don't have so much a good level of care. We need to discuss a little bit, I think, this issue of quality, this issue of accuracy. And I was particularly interested in your T1 mapping, which has not been adopted by very many people. I think it's at the moment confined to UK.
It is at the moment, but I really am very excited about T1 mapping. So we have done some studies with the Thai group, and we can T1 map very quickly, and it's very accurate. It's a standard MRI. It doesn't require any fancy software to do. And you can scan a lot of patients very quickly with it. So I think the T1 mapping is going to be hugely transformational, but we need more buy-in. The T2 star, as I've shown you, you can change, depending on the equation you're using, your T2 star could be 5 or it could be 26 for the liver. So what I tend to do is I tend to say that the T2 star actual result in milliseconds for the liver should be above 6 or 7 milliseconds, because we know that that generally reflects a low amount of iron in the liver. With the heart, I think, some of the really important things around T2 star are around making sure that the center that does the T2 star, whether it's in the heart or in the liver, they're doing the regular calibration, they're doing the regular checks and balances for their individual patients. And I think in a country, it would be really helpful if individual MRI centers cross-check their patients. So maybe have one patient do T2 star across 3 centers, if those are 3 centers in a country, so that you are all working towards a similar standard. In the UK, we do calibrate our machines regularly. We do appropriate monitoring. And I think it's really important that the calibration and the monitoring is kept a very, very close eye on. I've seen very, very silly results.
Okay, yeah, we totally agree. I just wanted this to be emphasized. And also, we should be looking on an international level at T1 mapping a little bit closely, a little bit more seriously.
Yeah, cheap and easy.
Mm-hmm.
There is a last question, Dr. Shaif, you may. I have a patient who presented 2 years ago with a ferritin level of 7,000. Today, after trying the Ferazirox alone and then the Ferazirox with Desferal, the serum ferritin level failed to decrease. So I switched her to Deferiprone and Desferal. The patient is transfused every 2 weeks. Why do you think there is these are failing? Or do you think in this case it's better to depend on the result of MRI?
I think the MRI is really important. I have patients who have very high serum ferritins, even with very low liver ions. If you remember on the slide, there was a FerriScan result with a patient of a very well-controlled liver ion, but a ferritin of about 6,000. So I would rely very heavily on the MRI assessments for those patients. If you've not done one, do at least one so that you know where you're starting. The other thing is that in the older patients, we've got to be thinking about fatty liver disease. And we don't think about these things at all. And we do need to be thinking about this because, as I said, our thalassemia people are normal people. They can get normal things. And we need to be thinking about that in addition. But I would, in that patient, I would be relying on the MRI assessments.
Thank you.
And also talking to them about compliance. You may be switching regimes, but are they taking them?
So the last question, is there an argument about chelation with dysferrioxamine in case of kidney problem? If you have kidney problem, can you use DFO? It's a question.
Yes, so we do. I would say if you've got a kidney problem, do not use XJade. We use Desferal, but we may use it 3 times a week on alternate days or 4 times a week on alternate days. And it's very effective. Remember, if the kidney isn't working, the Desferal hangs around for longer and it will be excreted a bit more slowly. So you need to reduce the dose, reduce the frequency, but you can use Desferal very safely in these patients.
Okay. So that's the answer to Anton, who says has around 300 his ferritin with moderate liver fibrosis. So what regimen of iron chelation do you advise? But of course you have answered already that DFO is okay. All right, and I don't think that we have any other question. What is?
Okay, no.
What is Antonov?
Yeah, the same, definitely not exchange. Yeah, for the cabinets, I think.
Yes.
So,
But
we said,
yes. Dr. Shah was clear, so we're keeping problem. The very not exchange. Okay. Anything else?
No, fine.
Thank you so much, Dr. Shah, really. And the webinars will be on our website with the permission of the presenter. But if there is anything that you would like to remove from your slides, you can, of course, let us know, and then we can add it on. Please note that this is part of our healthcare professionals platform effort in more specifically educating healthcare professionals on specific issues like iron chelation. Any other questions, I'm sure that Dr. Shah would be happy to answer. And thank you very much in anticipation. Dr. Michael?
No, thank you very much for Shah. And thank you very much to all who have been listening in. Thank you.
Right, thank you.
Thanks to Katya as well.
Kadia, you've been there. Kadia, thank you so much. Kadia, I believe this is our educational administrator who administers the educational platform. And she was the organizer of all these webinars. Thank you very much, Kadia.
Yeah, thank you, Dr. Shah, for your time and the very informative and clear presentation. Thank you.
Thank you. Bye-bye.
Bye.
Thank you.